Hello, everyone. Welcome to the SavvyCast. This is Jamie, and I am very grateful to all of you who are joining, whether you're watching on YouTube or listening to the podcast. Okay, today's episode is one that I'm hoping everyone not only listens to, but shares with people that you love, because today my guest is an expert on patient safety. She is a patient advocate. And if you do not already know someone who has been the victim of a medical error, you probably will in your lifetime. And my friend Krista today is going to help us prepare for that and hopefully avoid that. So before I go any further, I want to introduce my friend Krista Hughes. Krista, thank you so much for being on the SavvyCast to share this very important information.
Well, I thank you. I'm honored to be here that I can provide this information for your amazing audience that you have. So thank you.
Well, this is very, very important. I'm glad that you're here to shed light on this issue. But before we start, on a light note, would you just share what you might choose as your last meal?
So I was thinking about this, and I guess I would say maybe two things: spaghetti or Jamie's smashed potatoes. I'm a potato freak. So there you go.
Those are two of my favorites too. And I could literally go out on the smashed potatoes.
Yes.
So, okay. Well, Krista, first of all, you are a patient advocate. Can you tell us what that is and why you chose that to be your passion and profession?
Yes. So I worked in the operating room as a medical device rep over 20 years, and I covered 4 states. And while I was a rep, my dad has kidney stone disease, and they live out of town, and they were going to Montana, and they were flying out of Birmingham. So they came to stay with me. When he got here, he was gray in color and he was lethargic and out of it. And I was like, Mother, what's wrong? She said, oh, he has a kidney stone. The doctor said it's passable. They gave him 90 Oxycontin and told him to go have fun.
Oh.
So at the time, I just so happened was a kidney stone device sales rep. So I called my friend, a doctor, and I said, look, my dad, something's wrong. And he said, have him come in. So my dad went in the next morning, and my dad's never had any heart issues. And he said, your dad's now in AFib because of all the pain and the high medication of Oxycontin. He's gone into AFib. So we had to put him in ICU to get his AFib under control. And they removed the kidney stone. And the urologist said it was a golf ball sized kidney stone stuck in his kidney. And if he'd gone to Montana, he would have either gone septic and lost a kidney or died.
Oh, my word. My word. Okay.
So I quit corporate America and I started my company, Hughes Advocacy.
Now, may I ask you a question on that note? So what you're saying, that should have been caught. That never should have been allowed to progress. So that happened not outside of the hospital. That was a physician who didn't do his job, correct?
Correct.
And monitor that and whether they zap it or whatever.
You're right. He should have had a lithotripsy and had it crushed so it would have been passable.
Oh my word. Okay. All right. So you left the medical device sales world, which is very lucrative, great place to be. As I hear. And then, so you started Hughes Advocacy. Okay. So what is Hughes Advocacy?
Yes. So I became a board certified patient advocate, and most advocates now are board certified. We have to take an exam and keep our credentials. And there's multiple kind of advocates. There's private advocates, there's hospital advocates, and there's insurance advocates. So like if you go to the hospital, you might have a patient advocate come to your room. Or your insurance company might say, a patient advocate can help you with your medical. The difference is a private advocate works for you, the patient. We are not swayed by what the hospital advocate works for the hospital. So you have to realize the hospital's still paying their bills, even though they're helping you. they're working for the hospital. So a private is, we're going to send you to the best doctor no matter what hospital you're in. So that's the difference between the different advocates.
Okay. Now the insurance advocate, who pays them?
They're just through your insurance providers. They're
Oh,
hired
okay.
by your insurance company. So that's what I meant. They're working
Oh, okay.
for
So a
them.
private advocate's the only one, you pay them and they work for you.
That's the difference.
Okay. So how many private advocates would you say there are in the United States? And do you represent anyone anywhere?
So that's a good question. I don't know, because our field is growing rapidly because of the error. So I don't know. There is a total, could
Yeah.
not tell you. It's
Yeah.
not common in the South, and I don't know why. Some states have lots of advocates,
Mm-hmm.
but I've done this over 7 years now. I have clients all over the United States. I have
Okay.
clients at Mayo, Johns Hopkins, Cincinnati Children's, Houston. I cover anything birth to death. So my youngest client just turned 2 weeks old, 2 pregnant clients, and then my oldest is 94. So I do anything. I do inpatient rehab, skilled nursing, discharge, doctor's appointments, advanced directives, Alzheimer's, billing, anything to do with your healthcare. That's how I practice. Now, some advocates only do billing, or some only do Alzheimer's. So you have to find the advocates right for you, because my mission of my company, Hughes Advocacy, is to teach you and empower you to be proactive with your health, not reactive, to be your voice. I'm like a liaison between you and your healthcare system. And, everybody always asks, why do you even have this profession? And I mean, I'm not being ugly. I'm gonna be honest. Healthcare system's broken.
Yes,
And
it is. It
you
absolutely
cannot
is.
trust it.
No,
And sorry, let me tell you
COVID made
something.
it even worse. So, now I do want to ask you this, and then you can go into, you've got so much to share. I don't want to hamper you. All of those things that you do, your hands would be full with just 1 or 2 patients. Do you have multiple? You have a lot of people working for you.
No,
Okay.
it's just me.
Oh, it's just you. So how do you, wow.
I don't know. It's like one of those things. I was talking to somebody the other day and something came out of my mouth and I went, don't know where that came from. This is God's passion, because that was the Holy Spirit. I am not that smart.
Wow.
It really is my passion. When I was younger, I wanted to be a doctor. I love the medical industry. I work with some amazing doctors. I know I've shared with you, but I have the honor and privilege to serve on this committee, and it's called, I don't know why everything in healthcare is called the alphabet soup. Everything's an acronym. Don't know why.
Yeah.
But I work for AHRQ is the name of it, but it stands for the Agency of Healthcare Research and Quality. And what it is Secretary Beccera, who is over all of HHS, which is all the Health and Human Services. He appointed me to serve on this committee to advise him and Director Valdez on how to improve patient safety as the patient's voice.
Oh,
so
okay.
I was appointed, it's a 3-year term, and I go to DC, Maryland 3 times a year to report to the public things we're working on. So patient safety is so bad. And as you said, we were going to talk, I hate going over data. Everybody gets lost in data. And the reason I had to do a little data stat.
And it changes so quickly too. Data does.
Yes. And I'm not a data person. I work in the industry, so I see it. I don't need data to tell me, but there's new data that just came out in 2023 that I just wanted to let people know, because I think knowledge is power. And I don't mean to be boring, but 80% of your medical bills are wrong. And an example, I had a client that we were doing their medical bills, and they were a patient of a doctor. They did a telemedicine visit. And when they got the bill, the doctor coded as a new patient, which costs more, and an hour visit. That's fraud, and it's called upcoding. And a lot of people are like, well, it doesn't matter. My insurance, we have great insurance, covers it anyway. Well, are we not all complaining about our premiums going up?
And you have a lifetime cap. So if you're paying more than you should, you're going to make that cap earlier, correct?
these medical bills that are wrong, billing errors, that's what's causing our insurance prices to go up. So you need to not just say, oh, my insurance will pay for it. You need, because I called that hospital and I said, y'all aren't going to get paid for something y'all did not do.
So I think you're answering my question. I'm like, how do you take care of so many patients in so many states? A lot of what you do is on the phone.
Everything.
Okay. So you are not going to the hospital. Okay. Got it. Okay.
Now, I will have to say, pre-COVID, I did. And my resources were limited. I guess there's always a silver lining to COVID. Now everything is allowed to be over the telephone. And it's opened the doors. One, I'm not in this to take more money from patients. So like if you went to the doctor's appointment, it's an hourly fee. They're having to pay for me sitting in a waiting room. Now they just call me when they're in the doctor's office.
Okay.
So it's also a cost saving. So that is another way, is I do a lot behind the scenes.
Okay. And I'm going to ask you this, then I promise I'm going to be quiet, but
No.
I wonder a lot about, and I have some friends whose parents are in assisted living or memory care, and there are some horrible and very negligent things that go on. And of course, my personality is tell me who's in charge and I'll handle this, but you don't know who. That's very hard to find that. So is it safe to say you know exactly who you need to talk to wherever, and you're going to get to the bottom of it and you're not going away until you solve it?
So a great example is I had a client in January that was in assisted living that called me and said, my loved one at a rehab facility and has been in isolation for COVID for 10 days. And I went, no, I don't think that's right. So I called the quality director and she said, yes, it is. Well, I called CMS, which is the Center of Medicaid and Medicare in DC. And I said, is that true? And she said, no, the CDC guidelines are 5 days, not 10 days. So I called her back and I said, you're breaching CDC guidelines. You've got to get him out of isolation, because you getting him in isolation is preventing him for his rehab. So yeah, I stand up for you. I do everything professional, but I'm right and right's wrong's wrong. I'm fighting for my patient. It's nothing personal. It's kind of like we're lawyers in the medical field.
Okay. And you even know what to look for and ask for, where some of us may not. Okay. All right. Well, then just for my listeners and viewers, just tell us what some of the most common medical errors are, and maybe some examples, and then what we need to know and do to protect ourselves and our family.
And I did want to throw out a few quick statistics, if you don't mind.
Yes.
A lot of people don't know that medical errors, preventable, okay, that's your key word, preventable medical errors are the third leading cause of death in the United States. Now, because of COVID, I think COVID's now third and medical errors is fourth. So it's heart disease. I think it's heart disease, cancer, COVID, medical errors. But the key word is they're preventable. And it shouldn't, it shouldn't be in there. And I mentioned earlier, Secretary Beccera, who's over all of HHS, he had a meeting in November, and he was late to the meeting, and he came out and he said, I'm so sorry, I was so late. There's been a plane crash and everyone on the plane died. And, everybody had flown in. So of course, I was like, oh, what? And he said, no, this is a horrible joke, but that's how many people die a day of preventable and medical errors. So anytime you think of an error, think of a plane crash crashing today, and that's how many people just lost their life today. About 270 people. And
so what are those? Are they medication dosing?
I'm going to tell you all that. So everybody gets all confused on the difference of them. So medical errors, so diagnostic errors fall under medical errors, and diagnostic errors are when you're diagnosed, and they're most common in primary care settings, the emergency room, or in diagnostic settings. The statistic, a report just came out, I think it was last month, that 7 million patients are misdiagnosed every year in the emergency room. It's what's on the rise right now. It's what I'm seeing the most right now, but 12 million people are misdiagnosed a year, and out of that, 80,000 die from it. So there was a report that just was on NBC Nightly News, and it just aired, and I'm going to put my readers on and read because I don't want to misquote, but it said 1 in 4 patients that are admitted in the hospital will experience harm. It said these numbers are disappointing, but not shocking. Now I'm going to stop here and say why they're saying not shocking is data in healthcare is usually 2 or 3 years delayed. Nobody has been able to capture real-time data as of now. So this data was taken from 2018. So when they say it's disappointing but not shocking, I can tell you what I'm seeing in 2023 is the worst I've ever seen it in my 25 years in healthcare. The report said it's clear the rate is not going down and that harm is a serious issue. And one doctor said, you're going to be hospitalized, harm when you're hospitalized, and patients are encouraged to strive to be active parts of their healthcare team. And earlier I said one of my missions is be proactive with your health, not reactive.
Right.
In the 7 years I've done this, I've never had anyone that called and said, Krista, I just want to put you on retainer because I know something's going to happen to me. Everybody has called me with harm. And and last year I had 4 clients call me, and it was unfortunate, but it was so bad I couldn't do anything and they died. So nobody's reactive. And it's funny that everybody in healthcare is telling you to be reactive, but patients, the public thinks, oh, my doctor's good, it's not going to happen to me. No, it's not an if, it's a when. And when it does happen to you, if you don't know what to do, it keeps building and building and building.
So I get the ER, of course, you want to avoid it, but my goodness, that's first line of, even in now we have a concierge doctor. What do you think about, is there a little less incident with concierge because, you're paying out of pocket and they stay on top of things better. Is that what you see?
I do. Concierge, they spend more time with you. They listen
But
to
they
you.
don't go to the hospital with you though. That's the thing.
That's correct. And, I don't know the few that I've worked with, and I have nothing against concierge doctors at all because they're amazing primary care doctors, which are really your quarterback to keep you safe. But some of them are usually affiliated with a hospital system, and usually that's who they send you to if you need to go to a specialist. Where I'm going to send you to, if you need to go to Mayo, you're going to Mayo. You need to go to UAB, you're going to UAB. So I want you to go to the best doctor, not just somebody that you're affiliated with. But no, concierge doctors, they are phenomenal primary care doctors because they take the time.
Yeah. Yeah. All right.
And
Well,
back to your common errors.
okay.
That was long-ended. So I'm going to go through a few with some patient examples, and these are the most common I'm seeing throughout the United States.
Okay.
One is called, they're hospital-acquired infections. So they're an infection you get while you're in the hospital. You didn't go in with it, but you acquired it. And one example is sepsis, which sepsis actually is the #1 killer in a hospital. But I had a client that was in the hospital and her mother had an infection, and we told the doctor, we want her checked for sepsis. And she said, no, she doesn't meet the criteria. And I said, well, I think she does. She's got delirium, XYZ, we want her checked. And so we had to demand the care. And the doctor called back and said, she in fact had sepsis. So you're to demand the care that you need, and infections are really rampant. And I'll talk about how to find infections later. And then,
so in other words, this patient went in for something else and got sepsis in the hospital.
Well, had an infection, and infections can quickly turn to sepsis.
Okay.
You have to keep up with like infections or UTIs. That's from your catheter getting an infection in it. I've had that happen before with a client that I knew, talking to him, his temperature spiked and he was delirious. And I was like, have y'all checked? He had a UTI. They hadn't checked it. He needed an antibiotic. So you have to keep up on these infections. You have to, if you're in the hospital.
Oh my goodness.
And then there's hospital acquired conditions. And these are conditions that happen while you're in the hospital, like a fall or a wound. I had a client that was in a coma, and you're supposed to, if you're, sedated like that, they're supposed to move your body every so many hours, have a certain, and they didn't. And by the time she was discharged, they had to shave half of her head. They never moved her. And she had a mass, and then you have to go to wound care, and that can turn into an infection, and it was by her brain. So you have to be careful with those. A huge thing that no patient understands is care coordination. Everybody thinks my doctors are talking, they're communicating. Well, they're not. And it's because they don't have the time, systems aren't talking to each other. And I had a client that when he contacted me, he was like, I need a pulmonologist. And I was like, okay. He said, I've gone to 3. My cardiologist said it's my lungs and my lung doctors aren't listening to me. And I said, well, I really don't think it's your lungs. And I'm not a doctor or a nurse, but I can kind of put the pieces of the puzzle together. And I said, I really do think it's your heart. So I said, but let's go to your doctor, cardiologist, we'll go to your pulmonologist. Pulmonologist once again said, it is not his lungs. And so we went to the cardiologist and I demanded them do an EKG and he was in AFib. And so we then at that point, because they hadn't been checking him, he had to have a cardioversion and I got him a different cardiologist. And this client, the reason they called is he'd been in and out of the hospital for 3 years. It ended up that they had not checked his pacemaker in 3 years.
Oh my goodness. And he had been to a cardiologist several times and that never got checked.
And he just kept telling him, go to your pulmonologist, it's your lungs.
Oh my.
Like, no, it's not.
This is infuriating. Okay.
And so then another thing that is going on is unnecessary testing. I always tell my clients, no, you do not. They will tell you to do testing. Well, patients demand it. Sometimes they demand it. And I'm like, no, you don't need one. Like x-rays, sometimes they're good for 3 to 6 months. There's no sense. But then also hospitals can make money off unnecessary testing. And there's this doctor, he's Dr. Marty McCary. People might have seen him even on Fox News. He's a medical contributor. He's at Johns Hopkins.
Yes. I love him.
Yes. So he said that, and I'm quoting him, 15 to 30% of everything we do, we being doctors, tests, medication, and procedures, they're unnecessary. He said it's partly because of patient demand and it's partly to prevent malpractice. And he said, when your doctor orders a test, you need to ask why. What does he expect to learn and how your care will change if I don't have this? Because back again, when I talked about billing errors, he said, even if you have great insurance that covers the cost, the expense of unnecessary testing is contributing to our higher healthcare cost. So there's so much, we all complain about healthcare costs going up. Well, some of it's just lack of patience, not being proactive. I mean, like we need to start controlling and owning our own healthcare. Quit leaving it to them. So unnecessary testing is another common error. Now, these next few, I'm going to list them out and then I'm going to give one patient example because it'll hit every one of them.
Oh, okay. Great.
So obviously there's medication errors, discharge errors, early discharge. If a hospital discharges you too early, you're allowed to say, I'm not ready to go. If they discharge you early and you have to come back for that same problem within 30 days, you're readmitted, the insurance and you don't have to pay for it. So it's a big problem.
Okay. If you did not know that, let's say you didn't know that, is the hospital going to try to charge you?
Oh yeah.
So if you don't know that, you're going to lose that. Oh, wow. I had
I had a client that I knew he didn't need to be discharged. He needed to do on a walk. He needed oxygen. They didn't do a training for oxygen and they were trying to get him out. And I said, he's not leaving until you meet these criteria. And so we demanded, and they had to add a week because they did that, but they needed the beds. So back to discharge, access to care. We're knowing longer wait times, rural areas, telemedicine, patients. And like I said, I'm gonna give you a story. Patients being dismissed. We get it all the time. I've even had a doctor when I was asking questions, not being disrespectful, he literally put his hand in my face and said, don't speak anymore. Sometimes they don't want to hear you. They lie. And like I said, yes, they lie to you. And you're supposed to be part of the shared decision-making process. But this client reached out to me. He had cancer and he's on chemo. And he called me to help him find cheaper chemo drugs or a clinical trial. And I'm kind of like, I'm not a doctor or nurse, but I'm kind of like concierge. When people call me, I always say your body's like a puzzle and all the pieces should fit together. So I like to probe and get as much medical history. So I was doing a deep dive into his history and things weren't adding up. So I said, let's get you a second opinion. So I reached out to the doctor and told the second opinion doctor some of my concerns. And
second opinion oncologist.
Mm-hmm.
Okay, because this person had cancer. Okay.
So she redid testing and this was not unnecessary. We wanted these redone. And at the end of the day, he never had cancer and never needed to be on chemo.
You are kidding me.
And it's caused so much endocrinology problems and diabetic problems that we're in the process of getting his body back regulated from all the damage of the chemo meds.
How did the previous doctor misdiagnose cancer? Did he not have a tumor or a scan or a blood?
His was blood cancer. So I don't know how they missed it, but now when he called me about the cancer, I didn't think that was the issue. There were some other red flags that I saw. And the red flags that I did see were true. Now, I didn't know he didn't have cancer.
Oh, and then you just happened to find out through that investigation that he didn't even have cancer. Oh my goodness. Okay, now I have a question. Is that worthy of a lawsuit?
People always ask me stuff like, is it worth to sue?
Because it's probably really hard to.
Hospitals have money set aside that they
Yeah.
can tie you up. You can file, the laws are starting to change where you can start filing deficiencies to like CMS, which is CMS is who pays hospitals. They're the regulatory division of healthcare. They set all the rules for hospitals. Where there's about to be some changes coming because patients have got to start being heard. Obviously, I don't know if y'all knew about the Vanderbilt nurse that went to court because of the error. And there's been a lot of controversy. Should she or shouldn't he? And I'm not going to give my opinion, but I will say that the system failed this patient that died and we should go to court. And I want system changes to happen. You know, we're all human. Okay. And speaking of human, a great segue. We as advocates keep saying what is also lacking is empathy and compassion. Doctors just don't give it. I'm going to read this example. It's from a colleague of mine about not listening and dismissing. She had a small child, 9 years old, and the mother knew something was wrong and not right. She couldn't put it in medical terms, and she knew her health was failing. And the healthcare system lied to her. They dismissed her, wouldn't allow her to meet with the care team, and wouldn't let her have access to the medical records. And 9 days later, her 9-year-old daughter died in the hospital. So they do dismiss you. They do lie to you. I've been lied to before, and I'm like, are you really going to stick to this? Because come on now, we're in the profession of taking care of people. So like I said, there's not bad everywhere, but you just have got to be a proactive patient.
So do patient advocates do you have certain privileges beyond what the patient would have, or do you just have the skills and the expertise to know what to ask, who to ask, and how to get it resolved?
Yes. And everybody, I'm sure, is aware of HIPAA rights. And so if a patient hires an advocate, I always say, go ahead and call the hospital and add me so that I can speak. So I never speak for the patient. It's their decision. I just help them find facts. I do a lot of dialogue with the doctors behind the scenes. I help my clients prepare for their appointments, just so we can all make informed decisions. A lot of doctors I work with, I'll put it this way. I actually have a doctor I'm their patient advocate. Right before she retained me, she said, do doctors like you? And I said, well, I'll put it this way. In my experience and in my opinion, 90% of the doctors I work with love an advocate. We take time off them. They love it.
Making their job easier, and you're protecting them from getting somebody in trouble.
And helping their client. But the 10% that don't, I always tell clients, if they don't respect you having an advocate, then find another doctor.
Yes. Okay. Now I have to ask you, and this may be something you don't want to answer. You may want some people to contact you individually, but I'm already thinking I want Krista on board anytime can the common person afford a patient advocate? Because I'm sure, just like a concierge doctor, it totally comes out of your pocket. There's no reimbursement.
There is not. I know in my state, I don't know everywhere, but mine's a tax write-off.
Where are you? You're in Alabama?
I'm in Alabama. I'm in Birmingham.
So it's a tax write-off?
So I tell them
in Alabama. Okay.
Yeah, and it might be everywhere because I've never looked to see what the insurance rules are everywhere. So it could be everywhere. That I don't know. I've just never looked into another state. You know, some of my clients it's a retainer. So some of my clients I've had for 7 years, and I won't hear from them for 2 years. And then they'll call me like, hey, we're going to the hospital.
Now,
So
what do you mean? And I'm showing my ignorance here. What do you mean it's a retainer?
they
I
pay an
know.
upfront fee for so many hours. Each advocate does it different.
Oh, okay.
Even when they're not even using me, do I still have enough money in my retainer? Because I'm keeping you on board. And when you hire me, I include in the retainer your husband, your children, some adults, boomers, they have their adult children and their grandchildren all under one retainer.
Do you ever go like work for corporations who want to hire you for their employees?
That's something that's coming in 2023 is employers. Well, I've always said employers should hire an advocate because it helps an employer. I've had one here in Birmingham that the employer did call me and paid me for their employee. But that is something that is the wave of the future is employers hiring an advocate and then paying for it, which is a great benefit for them.
Okay, well, Krista, because I know I've kept you probably longer than we need to, but let's wind this down with you. Everything is going to be in the show notes, everyone, how to get in touch with Krista. She's going to tell us quickly about a bill that you can sign and mail to your specific congressman. Leave us with what's most important, Krista, because I know we can further get information from contacting you outside of this podcast.
Yes, and I did want everybody to know, because we didn't touch on it, 3 of the links below are hospital rankings.
Yes,
Hospitals are graded A, B, C, D, F. Your chances of dying in a C hospital are 80%.
Oh,
I actually had a client that contacted me after the fact. His mom had 61, fell bringing in the groceries, broke her leg, had normal surgery, which I knew this was part of the safety grades. I knew that you can have complications that cause kidney failure. And when he called me, he said, my mom went in with a broken leg and she's having kidney failure. And I said, and I couldn't do anything about it. She died 2 days later. But these resources are below, and it shows complication rates, mortality rates, ER wait times. So there are rankings, and it can tell you infection rates for each hospital. It can tell you, it's so much information to make you informed.
how often? Okay, because I'm a big advocate of health ratings in restaurants, because I used to be a food sleuth, whatever. I would go in and eat and then report, do the little thing. And I learned quickly those are very important. Don't eat anywhere under 90. And actually, the head of the board of the state of Alabama who does that, I happened to be teaching his child at the time that I was doing all this. This was before my girls were born. And he came and saw me at the hospital because his daughter told him, Miss Torrance hasn't been here. She's sick in the hospital. And anyway, long story short, he came and visited me. He says, I just want to tell you, don't ever eat anywhere with a health rating under 90. This food poisoning, we knew where I had eaten that week, and we knew exactly where it came from. So I said all that to say health ratings are, I believe, for restaurants are changed or inspected every few months. What about hospitals? How often are these statistics updated?
So they're updated like all the time. Like sometimes,
oh, okay.
Now the data, as I said, data in healthcare is always delayed. So you always have to so you're using it as a tool, but it is a very big tool. So it is delayed, but they always are updating it. And they're they're the CMS guidelines. They're what hospitals are held to. These are their standards. This is showing what they're failing at under the CMS guidelines for their regulations. So these aren't just makeup. These are federal guidelines that are laid out. So when you go in there, they're coming straight from CMS.
Okay.
And
so everyone can go to this resource that will be in the show.
3 of them.
3 of them. And you said never, ever, ever go to a grade C hospital.
Well, no, there's a ton of C hospitals. There's rarely A hospitals. There's a ton of C. There's a community here in Alabama, and all their hospitals are Fs, every one of them. And when that's
this in the stats that you're going to share,
everybody can look their own hospitals up. You can go look up your
own,
and they're F. I had a client call that lived in this community, and you have to realize some people don't have the resources to drive out of town. So if you have to, your only option is to go to that hospital You need to know everything that they're poor on and educate yourself, understand them, so that when you're there with your patient, because I tell people all the time, the caregiver is really the patient. The patient doesn't know what's going on.
Oh, that's exactly right. Yeah,
So
you're
the
right.
caregiver needs to always be, we as advocates say, don't ever leave your loved one in the hospital, ever, ever. That way, if you know they're an F and you know they're bad at sepsis, MRSA, falls, wounds, and you know the signs and symptoms, you can always be on top of it, even if your only choice is to go to a D or F hospital.
Okay. And I know I'll find this out because as soon as we press leave meeting, I'm going straight to those. Are there some A and B?
Uh-huh.
Oh, okay. So we can, all watching and listening are going to see stats that will be applicable to the hospitals in their state. So this is a United States state federal ranking. So why would all of us not choose, we're going to go to an A, period?
Well, sometimes your doctors are practicing at that hospital, and doctors are aware these are graded, and we encourage you to have a conversation with them. I saw that your leapfrog grade was a C. I want you to know, like I had a client that I prevented him from one of the errors at the hospital because I told the healthcare team, I want you to know, I'm aware that y'all are a D hospital and y'all have high mortality rates under this. So I let them know we knew about it. Let's talk about it. The anesthesiologist was able to talk about it. And that patient was a critical patient because he was having his leg amputated, that we were able to all watch the signs. So it's letting them know, having a conversation with them, being part of the shared decision-making process, and letting them know you are informed.
Okay. Okay. Well, I feel like you have given us an arsenal of things I want to ask one last question before we sign off.
Well, before we sign off, real quick, I did want to say one of the
yes,
ratings, real quick. I just saw this in my notes. One of them, you can look up surgery centers, and people don't realize this, but like, say you were having a sinus surgery and you can go look up surgery centers. And if the surgery center is only doing 10 sinus surgeries, but doing 1,000 orthopedic surgeries, you might want to go to a surgery centers that's doing 1,000 sinus surgeries, because that means they're not doing many. So you can even look up for outpatient surgeries. Is that surgery center a high volume for your procedure to keep you safer?
Okay. Okay. That's good to know as well. Last question. There's a specific specialty that I have a doctor and it's a specialty, and I wanted to change doctors, and they're all in the same group, and they won't let you.
That they don't have a choice. It's your decision.
Okay. Didn't know
People
that.
don't realize that we're the consumers. We're the customers.
Yeah.
And I tell people to always get second opinions or third, and they can't say anything about it. And good doctors, if you want to know the truth, encourage you to get second opinions. Encourage it. So no, if you want another doctor.
Well, they're all in the same practice, and they say you can't change within the practice. Okay. Well,
No,
Krista,
that used to be the rule, Jamie. That has changed, because I have some clients at a hospital, and literally this one doctor has been dismissing the patient. And I contacted the colleague and I said, she's being dismissed and not heard. Will you see? And they're next door to each, I mean, like they're in the same practice. And so we've got her, so you can switch doctors anytime you want to.
Okay. Okay. Wow. Well, Krista, I'll end by telling us what the link to how that it will matter if this bothers you, if this concerns you. We can go to the link that will be in the show notes. And what will that do? What's the timeline on that?
So December, there's a bill that just was introduced into Senate by a representative, and it's the National Patient Safety Board Act. It's never been available, never been offered, and it's going to run kind of like the National Transportation Act and the National Aviation Act, because we think that if you can fly and be safe, why can't aviation and healthcare work the same? Like, how come they can keep you safe, but healthcare can't? So there's now a bill. You can go in the link below and it'll open it up. And if you're interested in making a change for patient safety, we have what you can email to your representatives, and it explains the bill. So if patient safety is important to you, And what it is going to do, it's going to start giving patient and families a voice is what this bill is going to do. And we've never had a voice.
So they're going to look at how many people send these, and it's going to be, okay, we better take
No,
note.
it doesn't show that. It just gives you a template for you to email to your representative.
But the representative will see, oh, look, we've got our constituents.
Yeah. Oh, yes.
Oh, okay. Okay. It does matter. It's not a waste of time.
Oh, no, I mean, I'm in big conversations with my senator here in Alabama because they're aware of it and they don't really know what all the meat of it is. So I'm trying to educate them the importance of it. So if this is important to you, definitely go and send it to your representative for change.
And I said one more question I like. So I know you take clients anywhere, but is there like a national portal of patient advocacy?
There's several of them. So
it's a rising thing actually, because
there's maybe 5 or 6 portals. You can Google patient advocates near me. We're everywhere. I mean,
wow.
Like I said, there's so many databases now and we're all on it. And
well, I will say this. I had a conversation with some friends who use the same concierge doctor that we do, and we love him. He's great. It's wonderful. But this person made a comment and he said, but the problem is when we go to the hospital, we're going to see a hospitalist or whoever's there. He's not going to be going with us. You know, it's great for your primary care, but then you've got that. So I want to dig more into, can someone just call you as needed, or do you have to do the retainer?
It's funny. Everybody that always calls me.
I mean, this is a question. I know everybody's like, what does this cost?
No, we all do it different. And that's why I offer a free 15-minute consultation. But I had a client literally call me yesterday with a billing issue. And the more I started talking to her, found out she has 6 medical issues that she never knew she had. So a lot of people don't even know that you have issues. And then she was like, no, wait a minute. Now my husband has something. So now they've hired me. They didn't know. And she was like, thank goodness, because we didn't know what was wrong. We were being dismissed. And you're telling me I can't be dismissed? And I'm like, no. So usually now I have done some pro bono work. Sometimes if it's something I can answer quick, I don't do this to take advantage. I will help you out. But most of the time people are retaining, and I've never had a client not just keep me on retainer. They usually are like, I'm never letting you go. Like
listen, I need you. We need you. I'm so concerned about, I mean, I have a friend who got sepsis in the hospital. I mean, yeah, I know it's real. And it's probably even worse than we even know. So
they said there's data. We are all going to have an error happen to us. It's proven. And we all have to go to the doctor. The minute you're born, you're seeing a doctor. We all have to go to the doctor, and they need help from us. Patients are not proactive. We just go in the office and shake our heads and may or may not know what they're talking about. And I'm just teaching you to be more informed.
Well, I mean, I could ask you 100 more questions, but in respect for your time and schedule, I will not. Those of you watching and listening, please go to the show notes and reach out to Krista. Read all of the information that's there. And Krista, if you want Krista back, just email me, let me know. And Krista, I'm going to be talking with you off mic as well. But thank you for what you do and for sharing with my audience.
Well, thank you for letting me bring awareness to this topic, because it is getting worse and we're at a tipping point in healthcare. So people just need, back to knowledge is power. We just got to know to keep our loved ones safe, because you can't go to Target and buy a new life. I mean, you've got to really, and once it's ruined, it's ruined.
Yep. Well, Krista, thank you and blessings to you, my friend.
Thank you.